Good morning to everyone just joining us. We'll be starting off in a couple of minutes. Okay, good morning, everyone. We're going to start off. You're very welcome to the IEHG Grand Rounds. Today, we're hosted by St. Columcille Hospital in Loughlinstown. I'm Shane O'Hanlon, consultant geriatrician in Loughlinstown and in St. Vincent's. Also online on our panel today, we've got Tim Lynch, academic officer, and my colleague Tomas Breslin, who's NDTP training lead in the North Side, consultant emergency medicine. So we've got two great presentations today. First up is my colleague, Dr. Wan, who's a consultant physician in endocrinology and diabetes, and my colleague in Loughlinstown, also honorary geriatrician. I was just telling him last week, he's an expert at capacity assessments and everything. We're not going to go into that today, Wan.
No.
Got a very cryptic title, not just bloody nose. So over to you.
Thank you, Shane, Thomas, and Tim for the invitation. My name is Wan Aizat Wan Mahmood. I'm one of the consultant endocrinologists in St. Columcille's Hospital. The title of my talk today is Not Just a Bloody Nose. I'm reminded that the case presentation should involve a cooperation between various sites in IEHG, and this is one such case. Sorry, how do I change the slide? There we go. So in 2018, in November, MOB presented to the medical assessment unit, referred by his GP. He was 27-year-old male from the traveling community, and basically he had overnight episodes of epistaxis. He was recently diagnosed with hypertension, gastritis, and non-alcoholic fatty liver disease. He was started on ramipril 2.5 milligram by his GP, esomeprazole 40 milligrams. Other symptoms include 5 to 6 months episodes of night sweats and headaches, and also palpitations. In terms of clinical exams, his BMI was 40. He was very hypertensive at 231 over 113 millimeter mercury. Otherwise, his vitals was normal. Cardiovascular, respiratory, abdominal, and neuro examination was normal. At that time, he denies any headache. He had dilated endoscopy, which was normal, and no active epistaxis. Biochemistry, she demonstrated proteinuria. However, his renal function for blood count, potassium, glucose, and TFT was normal. His total cholesterol was 7.4 with triglycerides of 5.4. His ALT is slightly abnormal at 74. Otherwise, his LFTs are normal. So this was his ECG on presentation, which did not show any specific changes. However, his GP kindly provided to us a 24-hour ABPM, and you can clearly see that he has significant hypertension, especially at night time, with the absence of the nocturnal dip. So in MAU, because he was stable, the plan was to increase his ramipril to 5 and then 10 milligrams if no improvement down the line. and he was asked to go to his GP again to titrate his antihypertensive. But due to his age and the profound hypertension, he was screened for secondary cause of hypertension. That would include doing overnight dexamethasone suppression tests to screen for Cushing's, and he was asked to take 1 milligram dexamethasone that night. He also had a random aldosterone and renin level, random plasma metanephrine level, and then he was asked to return to medical assessment unit the next day for renal ultrasound. And thank you to our radiology colleagues who facilitates this. And he also was asked to do a cortisol the next day to look for the screen for Cushing's based on the dexamethasone suppression test. The full result came back in December. His overnight DST cortisol was normal at 16, therefore that outruled Cushing's. His aldosterone level was 7 with elevated renin of 7.6, and this gave an aldosterone-renin ratio of 0.92. And this is a screening for primary hyperaldosteronism. Unfortunately, we need to interpret this with context, as ramipril may downregulate aldosterone and upregulate renin levels. So this could be a false negative. But what was more pronounced was that I received a phone call from the lab, with a free plasma epinephrine level, which was significantly elevated. His normal adrenaline was more than 13,000, and my adrenaline was 2,800, with a normal 3-methoxytyramine. And this looks very suspicious for phaemchromocytoma. His kidneys was normal bilaterally on ultrasound, and post-Christmas, I contacted him with the results and arranged for him to come to our clinic as soon as we can. He then followed up scans CT tap with contrast in January, which demonstrated a mass in the right adrenal gland measuring about 5.8 centimeters. There was some mild para-aortic lymphadenopathy of uncertain significance. In the clinic, he felt well with 2 antihypertensive. Blood pressure was within normal range, and we had a detailed discussion regarding the diagnosis and plan. Of note, due to his background, he is illiterate. His wife could read a little bit, but there are a few family members who could read. So I gave him a copy of the letter so that if he wants to look at further information, he could get someone to read it to him. Sorry, my apologies. So I brought this case up with my colleague, Professor Crowley, and we agreed that this definitely looks like phaemchromocytoma. Therefore, we start alpha block him, and with amlodipine and an alpha blocker, his ramipril was stopped. We discussed his case in the multidisciplinary team discussion, monthly thyroid and adrenal in Vincent's. Ruth Pritchard was there as well, and we planned him for surgery. So the preparation for surgery would start with an alpha blocker first. I warned him about nasal stuffiness, fatigue, and postural hypotension, and the aim was to have a sitting blood pressure of less than 120/80, with standing systolic blood pressure more than 90. And I encouraged him to have a high salt diet. The plan was to start beta blocker prior to surgery to control any possible tachycardia. The agent that I chose was phenoxybenzamine, 10 milligram twice daily, and he was asked to attend the Diabetes Day Center weekly basis. And in the meantime, I kept Ruth updated as his readiness for surgery for the purpose of bed booking and theater slots. This is a table of his blood pressure throughout the follow-up. He required 60 milligrams of phenoxybenzamine 3 times a day. He did have some blood pressure drop, but on the 8th of April, then, because he was complaining of persistent postural symptoms and blocked nose, we felt that he was ready. On the 10th of April, he saw Ruth in Vincent's for admission. However, at that time, he had stopped taking phenoxybenzamine for unknown reason, and his blood pressure was not optimized. So there was a significant compliance issue there. At one point, we completely finished all the supply of phenoxybenzamine in the pharmacy, so we had to get some from St. Vincent's Pharmacy as well. But in view of the poor compliance or possible poor compliance, I admitted him to Loughlinstown, where he was restarted on the phenoxybenzamine. But quickly, then we realized that the stock is depleting, so I changed him to doxazosine, and this was titrated every 2 days. And it has a better impact on the blood pressure, perhaps because he was taking it. And by the April 2019, he had a persistent postural drop at doxazosine of 12 milligrams. At that point, he was transferred to Vincent's with the help of Ruth with the beds and theater slots. And he had a laparoscopic right adrenalectomy on the 25th of April 2019. Okay. So I could change slide. Okay. So in terms of microscopy, the tumor was 8 centimeter maximum dimension. However, the specimen was fragmented, so the size may not be as accurate. The tumor, it was a uniform nest of mixed large and multinucleated tumor cells. There was no capsular invasion or extension. Average mitotic count was 1 per 10 high power field. No evidence of necrosis or venous invasion or lymph node identified. The rest of the adrenal cortex and medulla was normal. The tumor was strongly positive for chromogranin and synaptophysin, and Ki67 proliferation index was less than 1%, which is good. And his PAS score was 3 out of 20, which means that this is less likely to have a metastasis. Post-operatively, he was identified to have a persistently low level of cortisol. So when he was discharged, he was discharged on a therapeutic dose of hydrocortisone. However, we did a synaptin test post-operatively without the steroid, and he passed it with flying colors. So we stopped the hydrocortisone. But the table below, you can see the levels of metanephrines, which was normal in 2019, and the most recent one, October last year, continued to be normal post-operatively. I had a discussion with him about sending a genetic test and the importance of it, and he agreed for it. Thankfully, there was no evidence of any pathogenic variant of familial Pheo or paraganglioma, and these are some of the genetics screening that we did, and we sent a sample to Birmingham, if I'm not mistaken. His blood pressure was well controlled on one agent alone, and he is attending us once a year for plasma metanephrines. Just a quick overview of phaemchromocytoma. So phaemchromocytoma is a rare tumor arising from the adrenal medulla. In the panel on the left there, so adrenal medulla is the innermost part of the adrenal gland, and it's from the chromaffin cell of the adrenal medulla. The panel on the right demonstrates the production of catecholamines in the chromaffin cell of the adrenal medulla. So how is that different than paraganglioma? So paraganglioma is also a rare types of tumors that arise from the extra-adrenal chromaffin cells. And these chromaffin cells are located in the sympathetic paravertebral ganglia of the thorax, abdomen, and pelvis, and these tend to produce catecholamines. However, there is also paraganglioma that could arise from the parasympathetic ganglia located in the glossopharyngeal nerve and vagus nerve and base of the skull. They do not produce catecholamines, so they tend to cause a lot of compression symptoms. So histologically, paraganglioma and phaemchromocytomas are the same, except that the difference is the site. So from now on, we would refer both of them as PPGL. So this is an example of paraganglioma found across the body. So the panel A there was a paraganglioma in the carotid body. B is a thoracic paravertebral paraganglioma, and C is a paraganglioma in the retroperitoneum area. and D is, two. Tumor one is phaemchromocytoma on the left, and the right paraganglioma in the pelvis, and E paraganglioma in the pelvic paravesicular area. Some statistics. Majority of the chromaffin cell tumors are phaemchromocytoma, about 80 to 85%. 15 to 20% are paraganglioma. Together, they are called PPGL. The incidence of about 0.6 cases per 100,000 person years, and the prevalence in patients with hypertension attending general OPD is as high as 0.6%. 5% of incidental adrenal mass, which we get referral often, are phaemchromocytomas. But 33% of patients with PPGL does have disease-causing germline mutations. These are mutations that we will look at in a few next couple of slides. An individual who carry this germline mutation in PPGL susceptible gene, their prevalence of having the PPGL is about 50%. And typically, younger age, multifocal disease, they tend to have hereditary PPGL compared to our case, which is sporadic neoplasm. This is a busy table, but I just want to highlight the column on the left. These are the way that these patients may present. So in our case, resistant hypertension, but some patients do have paroxysmal of hypertension, paroxysmal episodes of palpitation, perspiration, and headache. Not often, but it can happen that a plasma epinephrine was sent and it is markedly elevated. We also, it's very common for our clinic to get referrals for adrenal incidentalloma. However, if there are adrenal incidentalloma or retroperitoneal mass with attenuation of more than 10 Hans per unit on the unenhanced CT, it looks very suspicious for a more malignant tumor. This is a very busy diagram, but just to highlight the genetics that has been identified, the gene that has been identified as a hereditary PPGL. Some of them you would have known before with specific syndromes. So for example, the red proto-oncogene on the left, top left, there was the first one that was found to be causing phaemchromocytoma because it is part of multiple endocrine neoplasia type 2 or MEN2. You have heard of neurofibromatosis, where NF1 gene was responsible for it. VHL gene are responsible for von Hippel-Lindau syndrome, but the most important one that has bring the PPGL to the fore was the discovery of SDH mutations, and these mutation in responsible in the metabolism of Krebs cycles in the mitochondria, and it is as common as 30% of the hereditary PPGL would be due to SDH mutations. And at the moment, there are about 22 genes identified, but some of them has names, as you can see on the second row on the left, but some of them do not have any names. And the important things to know about why we need to identify these genetics is because it helps us to identify or look for other types of tumors. So for example, for a red oncogene in MEN2, we would look for medullary carcinoma and hyperparathyroidism. And for the SDH mutation, they may get pituitary adenoma, gastrointestinal stromal tumor, and renal cell carcinoma. And as you can see that the transmission are autosomal dominant, so quite significant, and there are the varying degree of frequencies in terms of the occurrence of adrenal tumor, head and neck tumor, extra-adrenal tumor, and also presence of family history, depending on which syndrome the patient has or which gene the patient carries. In terms of biochemical testing, plasma-free metanephrines is the most sensitive and specific. Make sure that the patient needs to be supine for 30 minutes to minimize false positive. Previously, and even now at some places, urinary fractionated metanephrine is still useful. It is a 24-hour urine collection in an acid bottle. Therefore, the challenge comes with any 24-hour urine collection. But we need to remember that the level of the 24-hour urine-free metanephrine to be significant, it has to be 3 to 4 times higher than the normal reference range. And we have to make sure that our lab measures the metanephrine using liquid chromatography or liquid chromatography and tandem mass spectrometry, but not using any immunoassays. The panel on the right just demonstrated medications that will falsely elevate the plasma and urine metanephrine. Some of them are common medications, such as paracetamol and metadopa, levodopa, transcranial antidepressant, and cocaine as well. So just to be aware when interpreting these results. In terms of imaging, CT is generally a good kind of modality. It has excellent spatial resolution. However, MRI is recommended for children, pregnant women, or patients with head and neck because the MRI is better looking at the lesions at this site compared to CT, or if you're looking for any metastatic disease. MIBG scan is a functioning imaging scan and suitable to be used in patients with metastatic disease when treatment or radiotherapy using MIBG is considered as well. And finally, FDG PET with CT can be used if metastatic disease is suspected or confirmed. So in terms of controlling the hypertension, pre-op preparation that we did in this patient was to alpha block him first, because when in phaemchromocytoma or PPGL, the adrenaline causes alpha-1 mediated vasoconstriction and beta-1 mediated tachycardia and inotropic action. So what happens is, if someone received beta blocker first, what will happen is all these vasoconstriction will push all the bloods into the heart and cause heart failure and pulmonary edema. Therefore, it's very, very, very important to alpha block this patient first before giving any beta blockers. So, and studies also have shown that adequate alpha blocker, which results in vasodilatation, lowers hemodynamic instability perioperatively when handling the tumor. So one take-home message today would be: do not give unopposed beta blocker in patients with suspected phaemchromocytoma. There are different types of alpha blocker that you could use. The traditional one that we use was phenylephrine, and these are non-selective alpha blocker, and they tend to be irreversible, and the body has to create a new receptor 24 to 48 hours post cessation. And in certain countries, they have been removed in favor of more selective blocker, and the selective blockers are doxazosin, prazosin, and trazocin. In terms of beta blockers, so once patient is a fully alpha block, the beta blockers can be used to control any tachycardia, and the aim was to get a heart rate of 80 beats per minute. Apart from labetalol, almost all beta blocker can be used. Labetalol may cause paradoxical hypertension, so probably best to avoid it. Calcium channel blocker, as mentioned, is a very good adjunct to alpha blocker for pre-op optimization, so you can use it liberally. Patient was advised to then have plenty of salt intake to help with volume expansion and plenty of fluids, and also pre-surgery they tend to receive intravenous fluids as well. And these pre-op preparation need to be done about 7 to 15 days prior to surgery to allow adequate time to normalize blood pressure and heart rate. In terms of genetics testing, as we saw early on, all patients with PPGL should be engaged in shared decision-making for genetic testing. And the reasons are, as we said earlier on, 1/3 of them may have disease-causing germline mutations, so very high risk. And especially if there is an SDHB mutation, metastatic disease can occur in 40% or more. And by identifying a hereditary syndrome in the proband, we can diagnose relatively early and other syndromic manifestation in relatives. There are currently 22 genes identified already, and red proto-oncogene was the first one. And there are about 10 clinically relevant syndrome with names on it, but there are lots of other susceptible genes, as you can see below. And by having different mutations, then it will help us to guide biochemical testing and imaging at diagnosis, and also follow-up biochemical testing. But in general, these patients need to be followed up by us for life currently. So this is some of the take-home message. I've presented a case of sporadic phaemchromocytoma that we know of so far based on his current genetic panel. In his case specifically, preoperative management can be quite challenging with poor compliance and side effects. Therefore, it's important to work together and coordinate with other sites. Phaemchromocytoma and paraganglioma are similar histologically, except for the site of tumor. And think of phaemchromocytoma when considering secondary hypertension, and no beta blocker if you suspect your patient may have PPGL, and all patients with PPGL will need genetic evaluation and lifelong follow-up. I will end there, and I'm happy to take any question.
It's very much fun for that really interesting presentation. Brought me back to medical school. It's you probably covered about 50 MCQ questions and answers there, so I hope we have some med students tuning in today. If anyone has a question, they can pop it into the panel. There's a Q&A panel there, or into the chat. So feel free to pop your questions in there, and we can come to them in the next minutes. One, can I ask first, should all adrenal masses be referred to an endocrinologist for assessment?
Yes, the short answer is yes, because we need to evaluate whether it's functioning or non-functioning. And this is a very common referral to us. Generally, if they are small and also has a low Hans failure in it, we tend to be less worried about it. But for the moment, I think it's best to refer all of them to us.
And how many of them would turn out to be a kind of an incidentaloma in your experience, all the different ones you receive?
So you're talking about non-functioning, like if it is when we screen everything becomes non-functioning. Majority of the cases are non-functioning. I would say probably 70–80%. Rachel might agree might support that, but very high risk, by very high percentage of them are non-functioning. And then I would guess then we have a discussion with the patient to decide if they want to leave it in or take it out. Majority of them would just leave it in because the surgery would carry the risk as well. If it is functioning, then with any hormones, then we can proceed with whatever the hormones that's functioning with it, and then take it from there.
Fantastic. And we might bring in Professor Rachel Crowley as well, who's joined us as a panelist. Rachel, just in case you want to comment on the case.
No, I suppose I was involved in this case, so I'm not sure I have a perspective from outside of it, but there are a couple of just points to reiterate. That one was saying that you need to know what you're doing when you're managing a pheo or a paraganglioma case, because in our hands, we've got great experience and they've gone very smoothly, but they can go really badly wrong. And they tend to go badly wrong when people don't realize it is a pheo or a paraganglioma. And, you know, in all innocence, particularly with the para where it's in another site. For adrenal lesions, just to follow up on what you're asking about incidentaloma, we say never stick a needle in one to make the diagnosis. And part of the reason is if it turns out to be phaemchromocytoma, you can precipitate a crisis. The other diagnosis that you really don't want to stick a needle in is adrenocortical carcinoma, because you instantly upstage that lesion to a stage 4 by sticking a needle in it, by breaching the capsule, if it is just an isolated ACC. So actually you get more information for diagnostic purposes from doing the proper CT protocol and from your functional workup than you do from putting a needle in them. It's really easy to miss the diagnosis. And then you need to just gather your team around you of physicians, your lab, your surgeon, your radiologist who are used to looking at them, and make a proper plan. I saw there was a comment through, and I think it must have been from Dr. Swan, just to reiterate that it's possible when we take these out to stain for SDH. And if SDH stains negative on these samples, then we know that's dropped and that they're likely to have a mutation in one of the SDH genes. And it has a prognostic effect as well, because SDH negative staining lesions are more aggressive and more likely to metastasize. I suppose everybody thinks that you do genetic testing for a family. In these patients, you do genetic testing for the patient themselves because it changes their own personal follow-up. And that's why we do it. We do the chat to them ourselves because we're the team that are going to be following them up with the screening and the biochemistry for the other associated lesions. And then if we identify a germline mutation in these patients, we refer our patients' families to Lisa Bradley in Crumlin for the cascade of testing beyond our patient.
Great, thanks very much. I see Tim Lynch has his hand up. Tim, do you want to come in there?
Yeah, thanks, Shane. And just as you said, it reminds me of doing my membership, and I'm getting sweaty here and getting a hypertensive, I think, but there you have it. It also reminds me of Zilva Pinnell, which was the clinical chemistry and diagnosis and treatment. And I don't know if that still exists, but there was that fantastic book by Zilva Pinnell that went through all these lovely, difficult endocrine testing. And I don't know if it's still around, but it was one of those Bibles that we had to review things, which was very helpful. If not, there's a gap in the literature and perhaps could be reactivated because this is a complex area. You've got to have it handy and have experts to be able to go through it. My question actually is what interested me about the traveling community, about communication. I think you touched upon that. This must have been difficult, and I'm interested in your comments on how you approach that, because the man unfortunately was illiterate, couldn't read, and often follow-up is difficult, and you could lose these patients very easily. And I suppose we're not that good in general. So what was your thoughts and how did you handle that?
So for me, I treated him, and mainly him and his wife. Basically, I treated them with like any patient I would have treated, and I keep reiterating the same message. And that's whenever I see him every week for the titration, we kind of reiterated the same plan so that he would understand it, the importance of taking the medications, and in the beginning there was a big crowd coming in, but I was like, well, perhaps maybe just you and your wife would be fine to come in. And on the surface, he seems to understand, and I've answered all his questions, explained to him on a regular basis. So that's the only way for me to be able to get the message across. For me, I didn't find it very difficult at all. Especially with there are some family members of him that he could read. In fact, at the end of our journey together, at that time, he did say that he is going to try to learn how to read and write, and whether he is taking it on board or not, I'm not entirely sure. But I'm happy that he decided to do that.
Brilliant. Okay, thanks very much, Juan and team. It's just gone 8:30, so we might switch over to our next presentation.
Thank you.
So Paddy or Rosa, if you want to pop your slides up first, and I think Rosa is going to kick us off. So Rosa McNamara is a consultant in emergency medicine across St. Columcille's Hospital and also St. Vincent's Hospital. And she's a clinical lead for the EDITH project, Emergency Department in the Home. So she's going to take us through that project today along with her team. Rosa, over to you.
Great, thanks very much for the introduction, Shane. As Shane said, I'm working at the moment across St. Columcille, St. Vincent's, and the two hospitals together with St. Michael's Hospital over the last 2 years have been working on a project called the Emergency Department in the Home team. The idea being that we would bring the assessment and skills of the emergency department out into the community. Because I'm not the one that does the daily care on a daily basis, what we've decided to do is we're going to, some of the members of the team who are working every day are going to talk to you. So I've got our RCSI Aspire Fellow in Silver Trauma, Dr. Patrick Hillary, who's going to do the bulk of the work. And then our senior occupational therapists, Lena Doyle and Aidan Delaney, who've been there since the beginning. So I'm going to hand you over to those guys.
You're muted, Paddy.
Apologies. In the share screen, I just have to find the different point for the button, so my apologies about that. So my name's Dr. Paddy Hillary. I'm as Rosa said, the RCSI Aspire Fellow. So I've working heavily with the EDITH program over the last year. So what we're going to talk to you today is about our service, what we do, the kind of cases, and a few cases as examples of what we see. So, in terms of St. Vincent's Hospital, in 2019, St. Vincent saw approximately 60,000 attendances. Of these, approximately 50% were over the age of 65 and over 18% were over the age of 75. Within that, at least a third of these were ambulance presentations. About a quarter of these ended up being admitted. So there's a large population coming through the department with a large proportion of frail elderly people who potentially would have admissions to hospital. We have a very large rural catchment area, so a lot of people think of Vincent as the leafy suburbs, but as you can see from this slide, our catchment goes the whole way down to Arklow. So there is a large part of our population that is within the extended Dublin metropolitan area and the more rural Wicklow and even north of Wexford. We're all aware of the normal movement of a patient through the ED, the normal triage, rapid assessment, early treatment, and then decision as to where a patient should be moved from the department. After that, the normal disposition methods of either admission to a ward for further monitoring, with the intention of hopefully getting people home into their own homes with treatment completed. But in the elderly population, this is not without risk. The risks inherent in admission for an elderly person are deconditioning, confusion, and delirium, all of which can complicate a patient's course of treatment. They can increase the length of stay and potentially have long-term knock-on effects on the patient's independence and their ability to function safely in their own home. So in that end, we have to think in the emergency department of what is the priority of the patient's needs, what can be deferred, and what is the risk here of the admission and of the discharging to another point of care. So to that end, Rosa and the team here set up the Older Persons Rapid Assessment Hub, or OPRA, and the emergency department in the home section, or EDITH. In terms of OPRA, this was the initial service setup that was inside the emergency department that focused on admission diversion, focused clinical assessment and functional assessment, and is planned for aggressive discharge planning to try and get people home or to another center of care within 24 hours, rather than bringing them into a high-tier acute hospital. At this time, we've seen over 4,000 patients, and approximately 70% of these potentially complex patients have been discharged directly from the OPRA service. Of these, the average age is about 82, but they range anywhere from frail patients at 47 up to the age of 103. But this was limited to what could be done in the hospital. So it was thought that we could move this outside the hospital and potentially bring the hospital to patient's own home and potentially prevent the need for them to attend the hospital in the first place. This was partially envisioned due to the fact that the NAS sees approximately 10 calls a day in our catchment that are older persons with simple falls. Initially, 100% of these were conveyed to the emergency department, and the average length of stay in the hospital for a frail older patient was approximately 22 days. And this would actually increase by up to 3 days if they had a delayed transfer to another step-down site, such as Columcille or another rehab site. So in terms of these patients, normally when they're seen by NAS, they need assessment to see if there's any injury, illness, functional or cognitive or mobility problems that could be optimized. And that would also be potentially worsened by their attendance at the emergency department, bringing them into a potentially deliriogenic environment where they don't have access to their normal supports or their normal medications, and such might actually functionally decline even based on where they are. So the thought for this was, could there be alternative pathways? Could half of these be kept at home, and could some of these be transferred to medical assessment units or elsewhere as a delayed transfer if appropriate? So initially this was set up with the National Ambulance Service as a pilot project, working with an advanced paramedic, an emergency SPR or registrar, and occupational therapist. They carried simple tools such as point-of-care blood tests, point-of-care imaging with ultrasound, and simple adjuncts that could be used to optimize their care in the home, such as rollators, frames or chairs, and things that could be set to keep people in their own home. So the initial pathway for all these patients would have been they would have been seen in their own home by an ambulance and transferred to hospital. The point of this car was that the frailty first responder team could go that route if they deemed appropriate, but also could refer people to other sources of care such as GP, public health nurse, community OT, community geriatrician, integrated care teams, or other centres of care such as the medical assessment unit in Columcille for reablement as opposed to an emergency stay in St. Vincent's, as well as being able to access outpatient care if appropriate. So this started in February 2020 with initial slunch care funding of approximately 200,000, and it was seen to be received quite well. The initial criteria for what we were seeing was strictly limited to 6 criteria, which is falls and frailty, general decline, confusion, immobility, new incontinence, or catheter problems. So specific catchments that for these patients coming from especially the Wicklow region, the risk benefit of having to transfer them up to the emergency department for a long stay there and difficulty with getting them home would not have been their best interest. Unfortunately, just after this was set up, COVID hit. And as you all know, this changed everything and made us re-examine the way we deliver our care. In terms of how it affected older people in the emergency department, due to the nature of COVID, we were seeing a large amount of clusters. There was also a decreased level of medical care available in the community, and there was also increased number of transfers to the emergency department. So there was one time, for example, when there was a call into the department here that there was 25 patients on the way down to us because this nursing home they all had COVID and they all needed treatment. So the team here took it on themselves to look at how can we do this differently, and instead of bringing those 25 patients into the department, they sent a team out to assess them. So this led to engagement with the hospital and the agreement to have the frailty response team work Monday to Friday as well as Saturday and Sunday, and that started up in April 2020. This led to an expansion from our original catchment, which was the Wicklow base, serving mainly the rural area, to the entire St. Vincent's catchment. We also expanded our criteria from the original 6 ones to also just generally medically unwell patients, nursing home patients with febrile illnesses, ED supported discharges, so patients who potentially could get home, but we just weren't happy with them, but thought we could get them home if there was a safety net of a senior medical review within a set amount of time. And also for support to other hospitals or other outreach programs. So people like CIT, people like palliative care, rather than them seeing the only option to get emergent care for their patients as referring to the emergency department, they could link in with the frailty service in the emergency department, and EDITH could potentially review them or direct them to other services. Basically, we were saying to these colleagues, anyone who thinks there's frailty that you're considering sending to the ED, discuss it with us, and so we'll see if we can do a better plan. And then the other side of it was, if there's anyone in the emergency department who potentially could go home, but you're just not 100% happy with them, but you think if they had a senior clinical review with the plan within the next 24 to 48 hours, that it's very appropriate to get them home. So this means that those patients who would have been kept in just in case, this was a better plan of how we could get them to their own home and potentially decrease their time in hospital. So where do you get our referrals from? Pretty much everywhere. And so from the 999 services, they divert to us, from local EDs, geriatrician hotline, nursing home liaison, integrated care teams, community and palliative care, public health nurses, and other community teams. So basically, we have very rounded areas of referral, and we try to integrate that through in terms of a timely manner. We, of course, do pay patients that if there's an absolute emergency, the ambulance service is your best interest, but it's another option. At this stage, we've seen approximately 5,000 patients, greater than 90% of these remained in their usual place of residence. The average age for these patients is 83. We do see some younger, frailer patients, the ones who have other comorbidities that would create them as frail, but the majority would be over age 83, and people into the hundreds have been seen by the service on a regular basis. In terms of type of calls, we see everything from falls, medically unwell patients, catheter problems, and pain and functional decline. As the bulk of our work will be those undifferentiated medically unwell patients who aren't too sick, but will be sent to the emergency department because there's no other place to get them an accurate diagnosis and planning. We often try to integrate the clinical frailty scale in our assessments. This is taken into account the patient's comorbidities, their baseline level of functions, and their likelihood of having good functional outcomes, and also the likelihood that they'll have negative outcomes if they attend the emergency department to seek treatment here. So again, these patients that are set up in their home, that we try and use that setup, those patients who aren't set up at home, that we try and optimize that setup, and those patients who can't survive at home, that we look at the best option for them as to where they could go. So as part of this, we think of the 5 N's of geriatrics, which is prioritizing patients' mind, mobility, and medications, while taking into account the multi-complexity of them, and realizing at the center of this, we should be keeping what matters most to the patient. And that's where we try and emphasize in all of our assessments. From our approach, as a GEM physician, we are concerned that it must be, we must get everyone involved as early as necessary. We want to move the patient's assessment to a senior physician at the earliest point of the patient journey. I want to activate community resources for the patient to make sure that they're not coming in seeking services that could be provided in the patient's own home. We want to localize people's own hospital network, and we want to make sure that we're justifying every admission and not just keeping in people just in case, but giving them a specific reason and a specific outcome, or taking into account the factors that are driving other issues and not just keeping them in just because. So following that, we're going to go into a few cases. This is just a classical case that we all would have seen over the last number of years. So a frail 93-year-old male with a significant deficit due to previous CVA, dementia, hoist transfer, and dependent for all care needs. So this gentleman would be have a CFS of 8, given the fact that he's a highly dependent gentleman. And he'd recently had clinical decline with increasing fatigue, decreased oral intake, and low SATs coming at the 92 to 93, where you'd normally be above 95. So we were asked to go with, this is a gentleman who typically would be sent into the emergency department, and with that comorbidity profile, there would be a high probability he would be admitted. This nursing home, though, had been one of the original outbreaks, and it had been the one that previously had 3 EDITH cars out to it, following 37 patients having the outbreak. So they were well aware of what was going on. The care staff had been aware of best interest patient management and had upskilling on it. And the patient had previously expressed DNA CPR and preference not for hospital transfer if available. But we would still like to deliver ward level management of this patient's care in the nursing home. As such, we used our St. Vincent's Hospital Optimal Management of COVID-19 in the Nursing Home pro forma, which is a document that was worked up by one of our SPRs here as to how we could deal with these patients better in the nursing homes. So the intention of this is that this dealing with this patient that of the current 49 nursing home and other home care facilities, that these patients can be treated appropriately in their own residence as opposed to bringing them into a hospital setting. This means we can give them hospital level care in the nursing home with oxygen, VTE prophylaxis, dexamethasone, and antimicrobials if appropriate, and as well as subcutaneous fluids if it would seem to be necessary. We also would have ceiling of care conversations if they've not been had already, and take into account the patient's and family's wishes as to what's the best care for the patient in front of us. And we would also look at what has been put in place or could be put in place from a palliative point of view to respect the patient's views and see if we can treat him as optimally as he would be in the hospital setting, because the majority of these patients would not be escalated to ICU, while keeping him comfortable and well in his own environment. So the next case is a patient that was actually referred to us yesterday. This is a patient who had a fall in a nursing home. He was seen and assessed by a GP very appropriately, who's looking after him in the nursing home, but he felt that the shoulder felt slightly abnormal. The patient had no pain, but due to his history of dementia, the GP had a concern that this might be a fracture that the patient wasn't expressing pain over. As such, the GP used the facility which we have set up in the area for community X-ray facilities, which is where mobile medical go out and actually perform an X-ray in the patient's out to residence. This did unfortunately show what is a rather nasty displaced neck of humerus fracture. So typically this is going to be very painful, but typically also will be treated conservatively in the majority of the population, at least in the interim. As such, the GP's plan had been to transfer him to ED to get optimized and potentially seek orthopedic review if appropriate. But as we were linked in with the medical X-ray service, they forwarded us the image to treat him in ED, and we said we could see him with EDITH and potentially avoid this transfer. So when on assessment, he had no pain, was neurovascular intact. He actually had good range of movement to the shoulder and was lifting his head above his hand pain-free. He did have it turned out that when he reviewed the notes, he had a history of a surgical neck of humerus fracture. So my impression was this is not an acute injury, or if it is, it's potentially displacement of an old healed injury. And given the patient as well, the first point of care for this gentleman should be collar and cuff, and repeat X-ray in the nursing home in 1 week. Thankfully, we were able to review his previous imaging and find that this was consistent with his old injury that never healed back from 2019. So this meant that this patient was able to stay in his own home, avoid unnecessary ambulance transfer, and avoid an unnecessary treatment in the emergency department, which was not exactly quiet yesterday, so would not have been a good environment for this gentleman to be in. So now I'm going to hand over to my colleague, our occupational therapist, Cliona Doyle, and she's going to talk you through our next
Thank you, Paddy. So I'm just going to talk through one case study to highlight the role of OT within the EDITH service. This case study is based on a referral from our own emergency department following presentation of an 84-year-old lady post-fall at home. So she had sustained a right radial head fracture and had a back slab and collar and cuff in situ for the next 6 weeks. Looking at her background, she is a very independent lady, lives with her son in a 2-story house and had no formal support. So she was independent with all mobility and ADLs, including personal care and meal preparation prior to this fall. And the doctor with me on the day completed a medical review, which was mainly focused on analgesia titration. And then I proceeded with their occupational therapy assessment and review. I looked at her functional mobility, her stairs management, her completion of functional transfers, toileting and self-care. The main difficulties for her was that her recent fracture meant that she was, in her dominant hand, meant that she was non-weight bearing and had restricted range of movement for a number of weeks, and how this would have implications on her performance in ADLs. At present, she remained to be independent with mobility, but had increased difficulty on the stairs as her rail on the stairs was on the same side as her fracture. She also was going to need help managing her meals and self-care for the next number of weeks. So the action plan for this lady in trying to maintain safety and optimal independence levels at home was firstly to refer to our action plan service to ensure expedited installation of additional stair rail. I provided education and advice on compensatory strategies, so managing her self-care with the one-handed dressing technique, managing her feeding one-handed as well, and dressing. Thankfully, her son was able to provide temporary additional support, so he would supervise her on the stairs, assist with meals and shopping, and provide assistance with self-care. And finally, I referred this lady to community occupational therapy and community physiotherapy for rehab at home to regain her range of movement in her arm and regain her previous level of independence once back slab was removed and a range of movement was allowed again. I'll just pass it on to Aidan to go through the next 2 case studies.
Hello everyone, Aidan Delaney is my name. I'm also one of the occupational therapists working on the EDITH team, and I'm just going to run through 2 more patient cases just to give you an idea of the type of presentations that we regularly go out to see. This one was for a patient who was referred by the National Ambulance Service. It was a 74-year-old male. He had a fall at home. The fall was witnessed by his neighbour. He didn't appear to have any head injuries. He had mobilised post-fall. However, he did have a noted elbow laceration, and the neighbour and the patient were reporting some functional decline over the past number of months. The patient also had a background of Parkinson's disease. The patient had a relatively good baseline. He lived alone. He had home help 5 times a week to help with showering. He was mobile with a walking stick, and he managed his ADLs independently. His neighbour lived nearby and was in regular contact and assisted with shopping, particularly during the cocooning stage. The medical assessment for this patient included a full head-to-toe assessment. The patient's elbow wound was reviewed, a full set of vital signs were completed, and the patient's medications were also reviewed. The occupational therapy assessment included a mobility review, so the patient was mobilizing close to his baseline. A cognitive screen was completed, so we completed the 4AT, which is a screen for delirium, which didn't indicate delirium. We also carried out a home environment assessment and a falls risk assessment. The action plan for this patient was the doctor on the team was able to suture the wound and dress it appropriately. We also sent a referral to the public health nurse for follow-up wound care. The doctor also reviewed the patient's regular medications, and the patient was advised to take regular paracetamol for pain relief. In terms of our falls risk assessment, we were able to provide the patient with falls prevention strategies. We gave advice regarding removing tripping hazards. We encouraged regular mobility, and we also provided the patient with pendant alarm information as a safety net in the case of future falls. We were able to send a referral to our handyman service to install a second banister on the patient's stairs, as this was something that the patient had reported that he was finding difficult. Just one moment there, sorry, Paddy. So my screen has just timed out on me there. I'll just give me one moment. Yep, sorry, I'm back. Sorry about that. We were able to send referrals to our handyman service to install a second banister on the patient's stairs, and we also sent a letter to the patient's GP and the patient was going to arrange a follow-up GP visit for a wound review and suture removal. So the outcome for this patient was that this patient was successfully kept at home with alternative care pathways in place, as discussed. The second case that I'm going to go through. Was for a patient who's also a National Ambulance Service referral. This time it was for a 73-year-old female who had a fall 3 weeks ago while holidaying in the UK, and that resulted in a fractured noff. The patient did receive some limited rehab while in the UK and was actually repatriated back to Ireland. And on our assessment, she had been home for a week. However, unfortunately, since returning back to Ireland, the patient had spent the majority of time in bed. She was requiring assistance of 2 people for transfers, and her family had been staying with her to assist with ADLs, and they were really struggling. The patient had a past medical history of rheumatoid arthritis and also had a left knee amputation a number of years ago. This patient's baseline was quite good. She lived with her husband. She had no formal supports. She was mobile with a walking stick and independent with her ADLs. The medical assessment included full head to toe assessment, review of vital signs, identified the patient's primary issue was the right hip pain, although the wound did appear to be healing well, and it was felt that the patient's pain medications could be optimized to enable further engagement in mobility and ADLs. The occupational therapy assessment concluded that the patient was off their functional baseline. They're requiring assistance of 2 people for transfers. They were mobilizing with a pivot transfer from the bed to the commode with great difficulty, and ultimately they were really struggling to manage at home. We had a conversation with the patient and with the patient's family, and we agreed that they were struggling to manage at home. We arranged and discussed the possibility of the patient being admitted to the medical assessment unit in Loughlinstown Hospital, and both the patient and the family were very keen for that. We were able to contact the medical assessment unit's team. We gave a direct handover to the medical reg, and we also gave a direct handover to the occupational therapist and physiotherapist in the medical assessment unit for immediate follow-up once the patient arrived. Sorry, this is just after logging out on me again. Just give me 1 second. So ultimately, the outcome for this patient was that an alternative care pathway was implemented, and we were able to give direct patient handovers to the medical assessment team in Loughlinstown. Traditionally, this patient would have likely ended up in the emergency department in St. Vincent Hospital and then possibly be transferred to the medical assessment unit. So we were able to minimize an unnecessary transfer for this patient, which was better for their overall care. Okay. So I suppose just to kind of summarize our own service, this is really a proven model of care to support people living at home independently. It has resulted in a reduction in avoidable transfers to the emergency department. Logistical issues around regular medications, meals, and need for special assistance in ED has been proven. In addition, infection control risk associated with hospital transfers, so patients would be obviously at increased risk of delirium. So we've been able to kind of minimize that, which is great for this patient cohort. It also highlights the benefit of client-centered functional and medical assessment, particularly in people's homes. What we've really been able to do successfully has been integrate both acute and community services to meet patients' needs. And feedback from patients and their families has been extremely positive, which really highlights where possible people prefer to be treated in their own homes. And I guess our approach ultimately is on a focus on admission avoidance, implementing alternative care pathways, and utilizing the local network of resources to meet patients' needs. So thank you very much. That concludes our presentation. And if anybody has any questions, we'd be delighted to answer them.
Thanks very much, Aidan. Do you want to stay there for the first question I have, Aidan, before you swap over to the team? I think we use the term revolutionary in terms of a lot of different projects in healthcare, sometimes quite loosely, but this is a true revolution in care, isn't it? It's absolutely informative. Have you had any political support for this project, or any recognition at political level that it's an excellent project?
Yeah, I can answer that. Yeah, so we were fortunate enough. We did have a meeting with the Minister for Health, Stephen Donnelly, who arranged a visit, I believe, off his own bat. He had heard about the service because we cover his own catchment area, which is a part of Wicklow. So he contacted the team to arrange a visit to meet the team, to find out a little bit more about the service, and was certainly very complimentary with regards to what we were doing, and certainly said that from his perspective, it was something that he was going to back, and felt that it was something that really should be rolled out nationwide. So yeah, so it was great to receive that feedback from the Minister for Health.
And I guess that goes on to my next question for Rosa or Paddy. Is there any reason that we shouldn't be rolling this out across the entire Ireland East Health Group or nationally?
I might take that question. Although I'm called Paddy as well on this, I'm sorry, it keeps defaulting. So the thing is, different models will work for different areas. So this model works across our 3 hospital group, because we know the resources, the community providers and that. So if you're asking, should you cut and paste this to Wexford or to North Dublin, it'll work differently. So, for example, the Mater has more contact with the Dublin Fire Brigade. So engagement with them is going to be much more important, and how those pathways work with the community providers in that care area. So it's, I think a version of it would work anywhere. I'd be very happy if my mammy in County Clare had access to something like this, if she fell at home, because she's had a few falls and it's a disaster, the big long trip into Limerick and everything. So if there was some sort of alternative that works within the resources of the care area. So it's all about the local healthcare network and the local healthcare community, and how those things can work together.
And I think the case, the example of someone having an X-ray in the nursing home, avoiding not only an ED visit, but probably a visit to the orthopedic clinic with 100 other people, somebody who has advanced dementia, taking them out of their environment, you can immediately see the benefits of that. There's one comment here. I noticed there were patients under the age of 65 reviewed, accepted. It's great to see that the focus is on frailty rather than strict age criteria and cutoffs. So do you want to have a quick word about your under 65 group that you've seen?
Yeah, so we have a high concentration of all kinds of residential care facilities. As Paddy said at the beginning, there's 49 outbreaks this morning of COVID, but about 10 of them are actually in younger adults residential and long-term care facilities in our area. So many of those residents are living with frailty. Just because they're not 65 doesn't mean they're not frail. Many of them are highly dependent, have cognitive concerns, and need a comprehensive and more, I suppose, intuitive approach to how care is delivered. And we would have that same attitude within the emergency department, older adult service as well. So we'll often see younger people with addiction as well who are living with frailty.
Fantastic. Tim, you've got your hand up,
Yeah,
and then Tomas as well.
Thank you. That was a great presentation. We enjoyed it. And I just echoed the comment about the under 65. Biologically, I was just thinking, is the person biologically frail? Is there other mechanism? And I always found the 65 mark really kind of a silly entity, frankly. It's really how we should treat the patient biologically. So I think that's nice. As a neurologist, I did notice one of the patients with Parkinson's falling, and I suppose I couldn't resist just commenting. One of the things I often look at is what caused the fall, and that sometimes we pass over that they've had a fall, and actually defining that and what the patient tells you is important. Is just a regular trip, and that does happen in Parkinson's patients. I had somebody in yesterday who fell early on in the diagnosis, and there was a question: was it regular Parkinson's or atypical Parkinson's? But he described very clearly coming out of a shed, catching his foot on the ledge and going over. Anybody can do it. However, in Parkinson's, one of the things you'll find with falling, you ask why it is. And what things that we miss are a drop of blood pressure on standing. And it really is helpful if we can get a postural assessment done, which is surprisingly hard to get, actually, and it's very useful to know that what happens like that in the community. And even if you get a 24-hour BP monitor recording, which I do, it often refers and reports on hypertension, not on low blood pressure, which is what I'm really interested in, because they crash and they have no warning, and they often just hit the ground. Freezing of gait with falls is common in Parkinson's. Sometimes that happens with the pills are overworking. They're on freezing with dyskinesia, and if you've got dyskinesia, it makes them topple over. And sometimes they've off falls, which is often going backwards. And then they all have polypharmacy, don't they, once they get to a certain age. So I often try and define what caused the fall and then see if you can then address it. Otherwise, they're going to fall again. And that would be interesting to see in your project how many of these are recurrent fallers, and are there those red flags, or are there as a particular focus on what is causing those persons' falls? Can you address it? Thank you. Nice presentation.
No worries. We do actually have kind of a minimum data set for falls assessment across the kind of acute settings of the emergency department and within the pre-hospital service as well. But we are very spoiled, Tim, because we have a fantastic Parkinson's nurse. So obviously a lot of the falls end up being multifactorial, and we'll do our best to kind of refine it, but we'll also link them back in with their usual movement disorder specialist.
And I suppose just to echo what Rosa said there, these patients would get the same assessment as they would have if they were in an emergency department by a senior emergency physician. So this is someone who will be seen by registrar level emergency physician, and their falls assessment will be taken out, and the appropriate comorbidities, appropriate medical abnormalities, the appropriate physical abnormalities to be looked at, as well as assessing the home environment, the gait and the vision issues. So it's a similar a review that they would have in an emergency department. But again, as Rose said, linking in very well with the Parkinson's team.
Great. Tomas, did you want to come in?
Yeah, in the interest of time, I'll keep it brief. Just well done, fantastic. And I agree, Shane, this is revolutionary, and we don't have it in the matter yet. We do have a fit team, which has been revolutionary, but we haven't got to that stage where reaching out. Very interested in your sort of algorithm to approach for COVID-19, and hopefully as we're getting out of that, would you consider having a similar one for a febrile person in a nursing home?
Yeah, I think, to be honest, because we've gotten used to working within that space, like we had a number of RSV outbreaks and influenza A outbreaks on the south side here in the last few months, and we've used a similar approach. So similar kind of what's the patient's, like what's important to them, what are their goals of care, and then what are the physical things that we're trying to sort out, and where are we going. So we were still using the same kind of approach and linking in very closely, obviously, with our primary care colleagues and nursing home medical officers as well.
And I love your point of care panel, is fantastic. Is point of care X-ray a possibility?
Yeah, so we've mobile medical diagnostics are working across the city, and the HSE has funded utilisation of their service in nursing homes. So we would use them very frequently. So if we wanted a chest X-ray in nursing home, they'll do it the same day or next day. In fact, I can see them texting me now, sending me chest X-rays from this morning already. So,
fantastic.
For example,
great work.
For example, that gentleman, when we thought it was a primary fracture, the plan had been, as opposed to bringing him into a fracture clinic, to get a repeat X-ray in 1 week to reassess the position, and as long as satisfactory, then we would follow him up as he would be in a fracture clinic without bringing him into a centre of care.
Fantastic. I think this is really the way to go. I love your term deliriogenic, and your comment on the emergency department being a bit busy. I mean, the emergency departments across the country are overwhelmed at the moment, as we've sort of supposedly gone back to normal. So I think this is definitely the way to go. So well done.
Thanks very much.
Ask one last question to Cliona, if you're still there, Cliona, just in terms of the OT perspective on this project. Clearly, as an OT, you're used to going out to do home visits as part of your training. Do you feel that this is a real subspecialty area that somebody needs to go into kind of permanently, or is it the kind of thing that also is suitable to rotate in and out as an OT?
I think rotation is definitely possible. I think we are quite autonomous on the car, so I think a high level of experience would be very beneficial before going out. We don't do home visits routinely from the acute hospitals. It's just not feasible, I suppose, with time and money constraints. So I mean, it's great from that point of view to have the car. I wouldn't be, I suppose, using it as experience for your home visits because they're very different to what a regular home visit would be like. I think, but yeah, definitely rotations I think are something that we can look at to upscale more OTs within Vincent's and kind of across the country. Yeah.
Great. Well, we look forward to watching what happens in future for this project, because it sounds like you're going to be expanding more and more. So hopefully your expertise will be useful to lots of colleagues around the group.